Hey everyone, welcome to Pop Health 101, a beginner's course to a healthier company. This is the fifth and final InspireYOU event of 2017. I'm Kirsten Bell, I'm the communications specialist for MJ Insurance, and I head up our InspireYOU series. InspireYOU has become something really special here at MJ. It's our chance to connect our network with content experts in those topics that matter most to you guys and are most relevant to you as well. We're also really proud to partner with SHRM this year, offering continuing education credits at each of our events. And that credit code will be made available for this event to all those who tune into the live webinar. So with today's InspireYOU webinar, our discussion will be with this goal in mind. We want to define population health past its trend understanding and explain its relevance to workplace wellness practices as you know it. And to help do that, we'll use two pilot programs to identify the challenges and successes with Pop Health. So let's run through our agenda and our featured speakers. We'll start with the background. What is Pop Health? What's the difference between it and other wellness programs you might be more familiar with? Next, we'll dig into our pilot programs. Those will be explained from both a clinical program perspective and a wellness perspective. And finally, we talk about next steps for those interested in Pop Health, or maybe those who haven't even started a wellness program yet and are wondering how to jump in. Your speakers today, we'll start with Shauna Hinley. She's our wellness coordinator here at MJ Insurance. Lisa Gish is the director of clinic operations for Tri-State. And Kristen Balshan is the director for client success for Marquise Health. So we're going to dive right in. I'm going to pass it off to Shauna Hinley, who's going to go back to the start for us and provide some background about what specifically Pop Health is and why it's so important.
All right, so health and wellness programs have kept data reporting in mind. Typically, you may have seen aggregated information on maybe your biometric screening results, some different health coaching programs, maybe participation in that, and even participation in different challenges. But the challenge here that we really have with wellness is that it's typically been designed to hit the masses and not necessarily focus on those who are targeted or at risk for different health conditions. Now, I'm not saying that we need to get rid of that from the past and just say, hey, we're not going to provide wellness programs in general, because typically those wellness strategies have kept your healthy population in those healthy categories. But what we're doing through this is taking it the next step and to focus in on a more detailed analysis of your population. So in addition to some of the data sources that you may have or data that you're receiving from your medical carrier, such as your medical claims, pharmacy claims, maybe some demographic information on your population, and even like large case disease management, we also have your wellness information. So maybe that's biometric information, again, some clinical information if you guys have a clinic in place, and some other details from a wellness perspective. The issue is being able to bring those data sources together and be able to talk. So if we're able to combine these data sets, we'll have a better or a more holistic approach in understanding the risk of the population, and then also be able to manage that care inside of the company from a better perspective. So talking a little bit more through this on the solution, the big thing here is, again, connecting those data sources. So your medical claims, the pharmacy claims, biometric data, if there's clinical data there, demographic data, benchmarking, so on and so forth, in a readily available and easy, readable fashion. From there, it's important to have the clinical team receive this information and then take action upon it. So we're going to dive in a little bit deeper here in a second on what exactly that means and how to take that forward. Okay, so we're going to start from the basics. Most of you probably know what a biometric screening is. Some of you may or may not already offer biometric screenings inside of your workforce. But the big takeaway here is the data behind the biometric screening. Biometric screenings are basic tests that can be performed on site with a primary care physician or even at a near site or on-site clinic. And it's collecting basic information about a person's current health status, such things like blood pressure, A1C or glucose, which is the diabetic risk, BMI or waist circumference, and lipid or cholesterol information in addition. What this data does when we collect it on the individual is allow the clinical or the outreach team to look at each individual's health prior to potentially knowing what the risk is through other data sources mentioned previously. So what I mean by that is it's really beneficial for us to understand this because we may or may not have any medical or pharmacy data on individuals. So if we have this biometric information as our first look, it's kind of a first starting point for somebody who, maybe somebody's just starting out at your company or they haven't used the medical plan that much in the past. It allows us to have that first initial look of a person's health status at that moment and a proactive look from that. From there, what we're doing is we're looking at the risk score of a population from your medical data, pharmacy data, and any clinic and benchmarking data. We here at MJ use the system or the Johns Hopkins ACG guidelines to assist in understanding the risk. There are a number of tools out there, but here we just use that to understand the risk profile inside of our population. The tool focuses a lot on 13 different disease states, which to name just a few of them, diabetes, hypertension, depression, lipid metabolism, and a few others. The reason we focus a lot of our attention on the risk profile is due to comorbidities within a population. So some of the things we found in the pilot is that we're looking at risk scores, so the low, moderate, and high was the most important thing to focus on. Due to, let's say, an individual was tagged with diabetes, what we found is they had a high prevalence with hypertension as well. So we didn't necessarily just want to look at the focus of diabetics, but also look at the fact that they might be categorized in a low, moderate, or high risk category, and then understand the comorbidities that come with that. So it's to better understand the care and issues at hand with a single individual instead of just looking at disease states specifically. As the risk scores are produced, the next thing we kind of move into is what we're calling gaps of care. These are identified again through the Johns Hopkins model I mentioned earlier. This is a lot to do with why an individual may be risked in a high or a moderate category. If an individual is managing their personal health, these gaps of care will be brought, or if they're not managing it, gaps of care will be brought to the surface in the data. So to give an example, there are a few main areas that a diabetic might have to do to be compliant or to not have those gaps of care. Some of those are getting an A1C blood test every 3 months, having an eye exam, a foot exam, and then obviously taking the prescribed medications for that disease. If an individual does not have those blood tests every 3 months, maybe they don't have an eye exam in that 12-month period, then they're going to be targeted in a high or a moderate risk category due to those gaps of care. So what this really is allowing us to do is understand not only where their risk is, but why they're tagged in that risk category. So if they're not being compliant with their medication, we would know that that's the reason why they might be a moderate or high risk profile. So what that also really does is it helps when we start engaging with that health coaching team. We're going to move through this and constantly, it's a detailed based on the risk profiling by the disease state for the outreach team to build additional resources and give them reasons why that score is the way it's scored. So the health coaching or clinical team can take the data and use it as they're engaging with these risk profiles in the individuals. But I think it's really important to note here and kind of pause slightly to understand the message that's being delivered to the individual as we're going through this. We're not going to want this to come off or feel as if it's a big brother situation, and we really want the member to have a comfortable relationship with the outreach team. So most times the conversation between the clinical staff or the outreach team and the individual is more about how the health coach can assist and what the areas are they feel that they can provide additional support around the specific disease states and risks. We never want that health coach to attack or make that individual feel uncomfortable with the amount of data that they may or may not have. So the conversation is never going to be about, hey, Shauna, I saw that you did not take your prescription for your diabetes medication. I see that you didn't do this, or I see you didn't do that. It's more about, hey, your biometrics may have looked like this. What else additional resources can we do, and how can we work together as a team to better serve that next step? So as we're moving through this, we're constantly collecting data. I think the big thing with this is measuring how effective the programs are. We want to make sure that we're looking at ways that we can get better and that we can further engage populations. And as we look through the 2 pilots that we're getting ready to dive into here shortly, we have areas of focus that are needed for change, and we're gonna go through those as a team so that we can understand how to change the strategy specific to that group and to that client. Our end goal with this is to allow individuals to better understand their health concerns, educate them to better make lifestyle changes, but at the end, to make lifestyle and maintain a lifestyle change. All right, so before we get into this conversation a little bit more in depth, we're going to introduce two health and wellness companies who assisted with a population health pilot for two of mutual clients. Recently, we ran this pilot program with it's about an 8-month period of data. One pilot was run with an on-site clinic provider, which is Tri-State Community Clinics, and the second pilot was run with a third-party wellness vendor. As a side note, who had no on-site interaction with the client, and that is Marquee Health. We're going to take about the next 30 minutes or so to discuss each of those pilots, the different strategies used for those groups, how this has impacted the two companies' medical plans, and then lastly, next steps and focus for each of the companies in their upcoming plan year. So MJ partnered with Tri-State and Marquee on specific health metrics to be tracked. This kind of goes to that measure and manage piece that we were discussing earlier. We provided information on member name, disease state, age, gender, relationship to employee, so employer, spouse in this state, number of ER visits, number of admits, key diagnosis, so if they've had a diagnosis previously, what that would be, chronic condition count, and then risk level by disease state. So that goes back to comorbidities that I mentioned earlier as well. Again, this data was identified through our analytics platform and also with our population health management system, which is the Johns Hopkins data that I mentioned earlier. So in return, Tri-State and Marquee also provided information back to us, so we were able to manage and measure this. Things like communication type, engagement level by disease state, and then specific outreach notes on the individual level. The next set of slides are going to outline what that data was used and track the effectiveness of the program and the medical program or plan. So with that, I'm going to go ahead and turn this over to Tri-State Community Clinics, Lisa Gish, to give us a quick overview of their company and data findings from the outreach done with the pilot group 1.
Thank you. I just wanted to quickly talk about our organization. We are predominantly an on-site, near-site, or off-site employer-based clinic organization, and we focus in integrating corporate wellness activities into those clinic types of care. So we focus on trying to produce measurable health improvements, making it convenient for employees and their families to get access, and ultimately reducing the increases in annual healthcare spending, so that ultimately does save our clients money along the way. The population in Pilot Group 1 includes a total of 407 members, and that includes both the employees and the spouses. 153 members were identified as having one or both of the targeted disease states, and those would be diabetes and hypertension. 121 were identified as having hypertension, and 36 were in the group identified as having diabetes. 32 members in this cohort were identified as having both of those disease states. This is a predominantly blue-collar population, and they're involved in manufacturing work with a nearly even 50-50 split between males and females. Most of the members do line work in their day-to-day activities, and a few of them do work at desks. It's an older population with the average age of 49. Of the 36 members that were identified with having diabetes, 23 of those were employees and 13 were spouses. And of the 121 members that were identified with having hypertension, 94 were employees and 27 were spouses. Now, this population does have access to an on-site medical clinic that provides primary care services. Lab tests are available to monitor health conditions like diabetes, and employees can stop in and have their blood pressure checked when the clinic is open, in addition to when they have scheduled appointments. There are several generic medications, including medications for both diabetes and hypertension, that are dispensed from the on-site medical clinic as well. A nurse health advocate also goes on-site for a few hours every week. While available to all the employees, she proactively seeks out the individuals that were identified in the pilot group that have these two medical conditions. She will either talk to them at their workstation or in private, and that's their choice, about any questions or concerns they have regarding their health needs, and she encourages them to remain compliant with all of the treatment recommendations, including necessary testing and medications. We have a great opportunity to improve the level of engagement with population health activities, as you can see on this slide. For both of the disease states, diabetes and hypertension, the majority of members are classified as being not engaged, with the remaining individuals classified as being either engaged or somewhat engaged. As you can see on this slide, the presence of the on-site clinic and the health advocate have had an impact, resulting in greater engagement for the employees when compared to spouses. Now, the spouses do have access to the clinic, but it's more naturally available to the employees. The presence of the on-site nurse advocate has resulted in the majority of communications occurring in person, which is desirable for this population. We do recognize that additional outreach is definitely needed to bring more members into being either somewhat engaged or engaged. There's a plan to add more hours to the on-site nurse advocate so she can reach more members with these two targeted conditions while also attending to the needs of the other employees.
All right, so really quickly too, I want to identify how we're categorizing the engaged, somewhat engaged, and not engaged. So to further clarify, those who are in an engaged category, that means that we're in contact with the outreach team at least one time per week. For those in a somewhat engaged category, it means that they were in contact with the outreach team 2 to 3 times per month. And then those in a not engaged category means that they were in contact with the outreach team less than 1 time per month. So what we're looking at here is we combined all of the data from the diabetes and hypertension categories to understand how the categories are affecting the medical plan. The number at the top right is the total cost of the entire population per member per year. So for example, their specific Pilot 1 group, $6,238 per member per year is the cost that Pilot Group 1 pays for their medical and pharmacy claims. As we're looking at the different categories and the subcategories, what we're finding is that not engaged category is typically kind of in the middle of the three. They're not the most expensive, as some of us may have, previously thought that they might be. But I think the big reason here and what we found is that they're simply just not using the medical plan as they're needed. So there's issues out there, and there's reasons that they're having those gaps of care and non-compliant issues, but they're not doing anything about them. So the non-engaged category, again, is looking at this. We're talking about those biometric screenings in the beginning, and why I think it's so important, because we're not seeing a lot of data from this category through the medical plan or the pharmacy information, but we do know that information up front as we went through the screenings to better understand if they are not using that, where they're falling in those categories as well. For the somewhat engaged category, they are across the board the most expensive of the three. Most of this in this specific pilot had to do with there was a large claimant here with a heart attack. We include this obviously because it's directly related to the fact that there's a hypertension focus. The group that we're still seeing the most high claimants is from time to time in this category. We're going to see those in this category, but a lot of them the cost is mostly toward the fact that they're using the medical plan a lot more. They're becoming more educated specifically around their disease or the issue at hand, and then they're going to the medical plan to use it. So here, the thing too is, as we're starting to educate them and understand that, we see that they're using the plan, and that lifestyle change is starting to happen. It just may have increased our costs initially in this category. So for the engaged category, we're noticing that this is the least expensive group. They're even cheaper than that of the entire population cost mentioned in the beginning, which is, again, the number at the top right. This group is managing their care and understanding those lifestyle changes in order to be that compliant with their care in the disease state. So the overall goal is obviously to get everyone into that engaged category as we're moving through population health. However, I think it's important to note that with most things and with everything, what we're understanding is that it typically is going to have an increase in cost in order to get there. But once we do level out and we get those costs to go down and move into an engaged category, the overall cost is lowering from the total population on average. So talking again, going back to the measure and manage the effectiveness of these programs, what we've done is we've outlined specific things or recommendations for pilot group 1 to change based on the data findings in this pilot. As we mentioned earlier, Lisa said that we had some spouse participation that was really low, and our employee engagement was fairly high for the groups that were engaging. And she also mentioned that we do have an on-site clinic. So to mention, obviously our employees have a lot more engagement inside of that clinic because it's in their environment. They see it, they hear it, they know it every single day, where our spouses may not, see that as much. It's not that they don't have access to it, but it's not right in front of their faces. So we need to kind of come up with a better communication strategy specifically to the spouse group to understand what this program really is, how to engage, and how to take those next steps for the spouse engagement specifically. The other thing is to just communicate in general about the population, targeted population health management program to the entire population so that they can better understand the offering and increase that engagement. As we mentioned earlier, the engagement on the employee was still slightly low, but there's some other targeted things that came into that. One being that, which is the last bullet on this, there are hours were maxed out for their outreach and health coaching. So even if they wanted to engage and wanted to communicate, this pilot group had the max amount of hours inside of their staffing for their outreach team. So it was suggested that we add hours for their outreach team to better engage, again, that next set of that population. The other thing is adding a layer of incentives. Incentives are the way of the world these days. And if we can provide another opportunity for people to engage and identify those areas through incentives, targeting those that are very specific, but then also allowing people to get stuff in return has always been seen as another way of engagement. So with that, we're going to push this on to Kristen Balshin at Marquee Health to talk a little bit about pilot group number 2.
Thanks, Shauna. Just as a background, Marquee Health is a third-party wellness provider based in Chicago, Illinois. Our focus on our programming is more on the holistic side, really putting priority on understanding habits and empowering behavior change. Our full suite of services includes entry programming, such as a wellness portal, maybe some challenges, all the way to a more comprehensive and clinical approach with biometrics, health risk assessments, and outbound health coaching. We can pull data from every level of programming to identify engagement and risk areas, although, as Shauna just mentioned, it's most impactful when there's an incentive included because we tend to grab more data that way, as well as when biometrics and health coaching are part of their programming. Part of implementation of every program includes integration with other benefit providers to ensure when our health coaching team is capturing a participant in the program, we're using that time to also educate them on other benefits that may be helpful to them. This might include nicotine replacement therapy that's covered under the medical benefit for someone looking to quit smoking. It might be referral into employee assistance programming for someone who might mention, a new stressor in their life that they could benefit from counseling, as well as introducing them to disease management if they're eligible for any chronic condition management or even further education on a new diagnosis. Within our pilot program with MJ Insurance, we utilized all the data available in the first year to identify participants that were at higher risk for chronic conditions as well as increased costs to the medical plan. So in this pilot, there's tons of information on this slide, but a couple of things that I think is most important, some of which Lisa also pointed to in their pilot group, that we worked with a manufacturing company that was based in more rural areas of Indiana. Most employees were blue collar, including a fleet of truck drivers with a few small offices around the state. So even though there was good communication from the HR team, there wasn't necessarily a ton of engagement on site because employees just typically don't report to an office every day. For the wellness incentive, both employees and spouses earned discounts off their premium contributions based on participating in the biometric screening. Their discounts increased based on their lab results being within a low to moderate risk category. So the healthier they were, the greater the discount tended to be. The identified population for the pilot was based on those that were engaged in wellness, as well as those that we had seen active within the medical plan and we had some claims data for. Within the wellness program, as previously mentioned, we had biometric screening data to help us determine levels of risk for chronic conditions. And then we were also successful in partnering with MJ to navigate the claims data, looking at who was utilizing their medical benefits for more preventive care versus those with claims with more reactive care. So an example of this would be someone who went to their primary care doctor for an annual physical versus someone who had claims for the emergency room. In terms of the clinical outreach for the first year program, we tried several different ways to communicate and connect with employees and spouses. So the first real touch point after the biometric screening event was participants were invited to review their results with a health coach to earn an additional incentive. So that conversation did happen on site. There were kind of events scheduled around this health coaching opportunity. During that conversation, participants were invited to continue with the health coaching program if they were looking to make a change. And this was really a big impact moment for us. One, because the data was still relatively new to them, so they were interested to learn more. And then also because they had that face-to-face interaction when a lot of these employees were remote workers. In terms of the breakdown, which you'll see here on the slide, with regards specifically to depression and then to lipid metabolism, we did identify from an employee versus spouse relationship on the depression side, almost equal amounts of employee versus spouse ending up in that category. And then for the lipid metabolism, we saw a greater risk for employees versus spouse falling into the lipid metabolism risk. So looking in terms of engagement, we did see spouses engage in the mental health support a little bit higher, and then also employees from the lipid metabolism engagement a little bit higher. Again, it certainly could be because of the distribution of the data. As Shauna mentioned, we only had about 1 year of runway data to be working with, and we know that year over year we can sharpen that saw and get a better understanding of better risk and engagement opportunities with the group. One thing I will mention in regards to the depression is that part of that integration piece from our perspective was working with the employee assistance program benefit, which we found helps as more participants are willing to engage with a health coach and maybe open up and build rapport with them about some of the stressors in their life that can then be referred over to the mental health counselor to set up EAP sessions as a softer entry point. So when applicable, and of course the participant shows the readiness to change, that's when our team is likely to make those referrals and just use that integration is a little bit of a stronger benefit. So opportunities from an improvement perspective, one thing that we had noted was just to focus on getting more spouses engaged. So overall, in terms of the distribution of participation overall, we saw that some spouses were slightly less engaged. And one way might be having more targeted communications directly to them. So even though we're communicating a lot within the workplace and within the workplace benefits, sometimes that doesn't make it all the way home. And so finding ways that we can, communicate more directly with spouses through home mailers might be a better opportunity to invite them and participate in the program. And then along with that, we did mention the on-site health coaching being a really big benefit. And so there's always the opportunity to invite spouses to participate in those events as well. So they're already making an event of it, so perhaps extending it to the family to participate in as well. So the next slide shows just in terms of the communication method, how we were able to connect with these employees and spouses. And this is really looking at beyond that on-site event, how throughout the year were we communicating with employees. And so you'll see the biggest impact was with phone calls, both from the depression side and the lipid metabolism side. So it's one thing to know that, some groups will feel like phone calls are not a good way to communicate with their employees because they're busy during the day and then they're working with their family and busy at night on other things, and they're not going to answer a call from a random number. And, it really is important to know that if it's important to the participant, it's likely that they are going to answer, knowing that this is a resource available to them. Another thing that really had a big impact was in terms of our home mailer. We did do a postcard, and we actually combined the messaging on the postcards for both the health coaching benefits as well as the mental health resources available through the EAP. So it was an integrated communication that we worked on together, and then we did send that directly to the home. So again, one of those areas for opportunity, maybe even just addressing that postcard to both the employee and spouse could be a better impact for next year. But we were happy to see that, that home mailer did produce some participants and engaging in the program from there.
All right, so again, I just want to make sure we identify each of the categories again. The engaged category, again, means that we're in contact with the outreach team at least one time per week. The somewhat engaged category means they were in contact with the outreach team at least 2 to 3 times per month. And then the not engaged category means that they were in contact with the outreach team less than once per month. So same concept here that we took with pilot group number 1. We combined both the depression and lipid metabolism engagement to understand how these categories, again, are affecting the medical plan for group number 2. The number at the top right, 5,835, is the per member per year cost that pilot group number 2 pays for the medical and pharmacy claims. So you'll notice it's a little slightly, well, quite a bit different than what we saw in pilot group number 2. But as we're looking at the subcategories, we're finding the exact same things as we did with pilot number 1. The somewhat engaged category is our most expensive group. They are also using the medical plan the most. Your not engaged category is those who are kind of in the middle of the road from a cost perspective in the medical claims and pharmacy claims. But they're just not using the medical plan as we expected them to, or they're not using it as we were expecting them to. But just understanding that if we can get these people to move to an engaged category, what we're seeing is that the risk of the profile and the cost associated with the individuals in that population are less than what it is on average across the company. So again, we're always going to see with something like this increased cost from an individual perspective when they're starting to understand, they're starting to be more educated on their specific disease states, and as they start to use the medical plan more. But over time, our hope is to get them and to move them into that engaged category where they're spending less than what we're seeing in the typical average across the company. So next steps, Kristen kind of outlined these as we went, so I won't spend too much time here. But again, communication is just key. I think it's a really, really important part of wellness in general, but let alone with a targeted outreach. If we can better understand how to engage that employee population that are not necessarily there all day on site and in the environment, and maybe use some different technology tools to get to the truck drivers or the delivery individuals, that can further be leveraged and understand how to engage in these programs. Also, consider learning or adding another layer of incentive. This group does have some fairly well incentives put in place, but it might actually not necessarily just be on their biometrics anymore and be a little bit more targeted to the disease state at hand. And then the next is just to engage in the population from an on-site perspective. As Kristen mentioned, we do have a part of the population that does have on-site experience, and if we can give them a different way to grab a relationship and create a relationship with a health coach, doing an on-site option can be a next step for them to engage and further see engagement in that population. All right, so as we're walking through all of this, it's really important to understand that population, again, does not happen overnight. No matter where you are in your wellness journey, it's something that we can start working towards. You may know that there's some groups out there that are potentially contemplating wellness. Some may have a fairly decent, robust solution in place right now. But the most important thing is just to know that it's important to understand where and how your data is speaking to each other. So again, if we have all of these buckets and silos of data and none of them are coming together, then we don't really know the full focus or the full approach to take when we're talking about population health. We're missing a lot of pieces. And then what is the next step, right? What are you doing with that data once we're identifying the issues at hand? And how can you provide targeted approaches to those issues with your partners in place, with your wellness vendors and your outreach team?
All right, everybody, that's a wrap. I want to definitely thank our speakers, Shauna, Lisa, and Kristen, for providing their expertise on what can be a very complicated topic, making it seem easy and starting from the beginning for us. We have provided their contact information, so please feel free to get in touch with them. You can also rely on your consultant to get you in touch with these types of people, whoever you're working with for your wellness right now. And as you know, MJ is a proud partner of SHRM. This is our first year offering SHRM credits at each of our events to attendees, and we've really enjoyed inspiring the success of all of you both personally and professionally. We hope you'll join us for the 2018 season to do the same. That's a wrap, everyone.